Every day, a person's kidneys process about 200 quarts of blood to sift out about 2 quarts of waste products and extra water. These little cleaning stations are vital to life. Why we need to take care of our kidneys. The doctors are on call tonight. Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
Normal kidneys clean the blood of excess minerals, fluid, and wastes. But that's not all. These 2 fist-sized organs also make hormones that stimulate bone walls to be stronger and stimulate bone marrow to make blood. Kidney or renal disease affects more than 10% of adults and is the 8th leading cause of death in the United States. Many are unaware when their kidneys are being harmed, and so we tend to ignore these noble organs until it's too late. Your blood pressure running too high can result in not only small and large strokes to the brain, but also progressive loss in kidney function. However, the biggest threat to kidneys on the horizon is obesity with the resulting diabetes. It's anticipated that as our increasingly obese population matures, the dialysis business in this country will explode. Tonight, we are pleased to have a kidney expert to help us grapple with this evolving problem. Dr. Arvin Santos is a nephrologist practicing at the Avera North Central Kidney Institute in Sioux Falls. Welcome, Arvin.
Thanks for having me, Rick.
So tell us a little bit about you. You're, now, Arvin Santos, that's an unusual naming. Where did you grow up?
I actually grew up in the Philippines, and I did most of my training in the East Coast.
So now, in Boston.
Yeah.
Where in Boston?
I did my training in the Caritas system in Boston. It's now part of the Tufts School of Medicine.
So, and you did your internal medicine residency there?
Yeah, pretty much.
And then nephrology?
Nephrology, I went to Vermont, where most of actually my partners trained as well. And that's the reason why I was brought here as well.
Oh.
There was this connection between Vermont, in the middle of the East Coast, here to South Dakota.
So I didn't realize that. A lot of the nephrologists from Sioux Falls are Vermont trained.
Yes, most of them actually. For example, our lead nephrologist, Dr. Santella, is actually from there as well. One of my previous partners, Dr. Melanson, was also from there. She now works at, as you know, in Prairie Lakes.
Prairie Lakes in Watertown.
In Watertown, yeah.
So how long have you been in Sioux Falls?
2009.
So, and you've been doing outreach in several other places. Where do you do that?
Pretty much I drive 1,700 miles a month, Rick.
Oh, is that right? So that's a bunch of places. I mean,
basically I have my nurse drive me. So, but it's a bunch of places. I go to Brookings twice a month. I go to Sisseton. I go to Mitchell. I go to Gregory, South Dakota.
That's a long ways.
Which is a long ways.
Yeah.
That's roughly more than 300 miles back and forth. So
you do that in one day generally?
Usually in one day.
So you're home in Sioux Falls how many days a week? At an average, you're gone 1 day a week?
Probably usually 1 day a week. Yeah.
So, and then your practice is involved in patient and outpatient and dialysis as well, right?
Pretty much. Some practices actually do one of each and have each doctor do something, either an inpatient and an outpatient. But in our practice, we do everything.
So you have a general experience. I mean, I really like that.
Sure.
As a general internist,
yeah.
I do outpatient medicine. I do hospital medicine as well.
Yep.
So I have both sides of it.
Pretty much. pretty much. We're basically internists, but we specialize in kidney disease.
Right.
That's it.
Yeah.
Yeah.
So, if of all the things that you do, what's the most challenging?
It's taking care of sick patients. Unfortunately, patients who have kidney disease are one of the sickest patients around. So it takes a lot of time, a lot of effort to talk to them and take care of their diseases. And unfortunately, most of them have
more than just kidney disease.
More than just kidney disease.
Yeah, I mean, it's kidney disease is often a vascular, a blood vessel disease. And when you got vascular disease of kidney, you've got vascular disease of the heart and the brain and the lungs. And
the way I tell my patients are, if the first thing that goes are the kidneys and the last one that comes back are the kidneys. So when you see a kidney specialist when you're in the hospital, you're in trouble.
Yeah, because that's tough times.
Yeah.
So and what happens is the kidneys fail.
Yeah.
They have all these other things that pop up along the way.
Pretty much.
And you do a lot of inpatient dialysis?
We do, definitely. In the Sioux Falls, we do that quite a bit. Unfortunately, a lot of the smaller hospitals in the surrounding areas don't have an inpatient dialysis unit, so most of them are brought to Sioux Falls for that.
Right. Now, there's a lot of outpatient dialysis going on, too.
There is.
And we can talk about different kinds of dialysis, but I'm sure but you also don't do just dialysis. Let's talk about other things that you do in the outpatient or inpatient scenario.
So basically, chronic kidney disease has a lot of, you have a lot of issues when you have chronic kidney disease. People think that kidneys just clean your blood and makes urine for you. But as you told earlier, kidneys do a lot of things. So they regulate blood pressure, they regulate your electrolytes, they make sure that the bone marrow produces blood. So they do a lot of things, among others.
And so when the kidneys are failing, these other things happen as well, don't
they? Exactly. So, but other things that you look into, kidney specialist also looks into high blood pressure and other problems like blood in the urine and those things.
Tell us a little bit more about a normal kidney.
Okay.
You just described a lot of the things.
Sure.
So the kidney really filters the blood to try to get a lot of the things out into. So how much blood runs through the kidneys in a normal day?
Usually, there's 100 mLs per minute of blood that passes through the
100
kidney.
mils is what, a cup?
A cup per minute in one nephron, which is a part of the kidney.
Right.
So roughly, probably 5 liters gets cleaned out in an hour of your blood. So your blood gets cleaned out multiple times a day.
5 liters, which is really
all
your blood.
All your blood
gets completely pushed through the kidneys every single hour.
Pretty much. So if you think about it, that's a lot of cleaning that goes on in the kidneys. And the kidneys, as you said, are this.
Yeah, these 2 fists.
2 fists. And they do it all together. They secrete hormones, they clean the blood. So they do a lot of things.
Yeah.
So that's the reason why I became a kidney specialist.
What's the story?
It's because the kidneys do a lot of things. It's not like the heart that just pumps blood around.
A boring organ
exactly.
just pumps, nothing to it.
The funny thing is, we always get into arguments: a lung doctor, a kidney doctor, and a heart doctor. Who is the more important organ?
Yeah.
And they tell me that the heart is always the more important because it pumps blood around the.
Yeah. The neurologist, they always say, no,
because it's the brain.
It's the brain.
Exactly.
But without any one of those, we're in trouble.
Yeah, definitely.
So I know that the kidney is the one that controls how much urine you make, because there is a hormone that decides how dehydrated you are. If you're really dry, you're crawling across the desert, you really need to hold on to every little ounce of water that you have. Kidneys can almost hold on to all that water, and then you compare that to the time when people are just pouring the water down. I remember Dr. Tuttle, who was a grand old nephrologist from Emory when I was training, had just done this experiment, and I remember hearing about it. He started an IV in himself, and he tried to get it going as fast as they could pour the water in him to see if they could overload him.
Yeah.
right? He had good heart, had a good kidneys, he's perfectly healthy, probably 50 years old.
Sure.
Right? He couldn't overwhelm his kidneys.
Yep.
They could pour it in as fast as his kidneys could dump it.
And that's actually one of the misconceptions, because there's an old wives' tale that you need to drink 8 glasses of water a day. And that's true. That's true if your kidneys are normal. And your kidneys can process the water pretty nicely.
Yeah.
But for example, if you've got kidney problems, that sometimes becomes an issue. So,
or if you have heart problems.
If you've got heart problems, exactly.
Or if you have lung problems. Sometimes you have pulmonary hypertension, you're overloaded that way as well.
Exactly.
I think there's probably not one pill that I prescribe more than a diuretic.
That's true.
And yet all these people think that we need to drink all this water.
Exactly. And some people get in trouble with that, especially the elderly folks who are on medications that keep the water in the body.
Right.
And what happens is it dilutes out everything. And when that happens, people get confused.
Yeah.
And those things.
The hyponatremia.
The hyponatremia.
Low sodium condition.
Low sodium condition. Exactly.
What about, let's move to the question of salt, because people ask about salt all the time. I know that everywhere you look, oh, you shouldn't salt, you shouldn't salt, you shouldn't salt. And then that question is constantly back and forth. There's been new data that says, oh, you can salt all you want because your body gets your kidney, which when they're working good, can control it.
Definitely.
Or you need to hold off, all people need to hold off because then you won't hurt your kidney. What's your take on salt?
So salt equals evil for me.
Oh, you don't like salt?
I don't like salt because salt actually is the main cause of high blood pressure. There's been studies that show that Americans actually take as much as 6,000 milligrams of salt a day. Rick, what do you think is one Big Mac? How much salt is in one Big Mac? Just the sandwich, not the French fries.
Now, I mean, the normal recommended is 2,000?
Yep, normal recommended is 2,000.
So normal recommended salt intake is 2,000 milliequivalents? Is that what you called it?
Pretty much, yep.
Okay.
So one Big Mac, how much is one Big Mac?
I'd say close to 2,000.
Probably not that much.
But
it's
almost,
very close.
It's 1,000.
It's 1,000. So that's one Big Mac. So if the recommendation is 2,000 milligrams, and you eat one Big Mac for a snack, that's 1,000.
But I have read that that salt does not itself begat hypertension. That there are many other causes of hypertension. It isn't salt in many cases.
That's true, and it depends. If you've got kidney problems, you can't get rid of the salt, and unfortunately, when you grow older, the salt handling is different. If you're younger, then salt would not be a problem.
Particularly if you're an exerciser.
Exactly.
And
if you lose a lot of salt, for example, through sweat and those things, you definitely need salt, and that's where Gatorade comes in and those things.
Yeah, Gatorade has salt in it.
Salt, it's loaded with salt.
Right, and then the other question is, I've heard that the perfect electrolyte replacement. Let's talk about the Brookings Marathon and Half Marathon is coming up this Saturday.
Sure.
I'm running in the half marathon.
Okay.
Okay. And I know full well that sometimes at the end of the run, you're really exhausted your electrolytes. Little kids who have bad diarrhea are another group that exhaust their own electrolytes and their volume and they need to replace it.
Sure.
People always talk about the perfect replacement is Pedialyte because it's got salt in it and it's got potassium in it.
That's true.
Then I've heard other people say you can use Gatorade and white grape juice because white grape juice has the potassium and it doesn't have the diarrhea-inducing agent that purple grape juice has. And then you add it with, and you've got your Pedialyte.
And another thing is actually coconut juice. Coconut has a lot of potassium in it, and that's why it's in vogue right now to use as a
replacement. Coconut juice.
Yeah.
I've heard some things about coconut oil being extremely healthy for you. What have you heard? Like a lipid-lowering drug or heart protector? You've heard any of that?
I haven't heard about anything.
Okay.
My dad actually takes it though. So.
He does. He does. I've heard that coconut stuff, but I know no data.
Yeah.
I have no data, and neither do you then.
No, I don't.
But coconut has potassium in it. That's interesting.
That's true.
Add coconut juice to your Gatorade and your white grape juice, and boy.
It's actually interesting because potassium actually helps lower blood pressure. So if you've got healthy kidneys and everything, potassium is actually very helpful And that's why we actually recommend a high potassium diet. And usually that's fruits, vegetables, and those things.
Now, let me ask you this.
Sure.
There's a lot talked about. We've spoken about diuretics. People,
Yeah.
or a lot of people are on diuretics. A lot of my patients are, particularly because I have a lot of older patients or younger people with hypertension. But potassium is a big issue, and I always monitor potassium because sometimes diuretics will cause the potassium to be depleted.
Sure.
Commonly, particularly if there's heart failure, I'll use spironolactone.
Yep.
Talk to me about spironolactone.
That's actually one of my favorite drugs to use. Spironolactone is, for the audience, is actually a potassium-sparing diuretic. It actually blocks one of the hormones that goes higher with high blood pressure, which is aldosterone. And it's an aldosterone blocker. The nice thing about that is when you put it with some other diuretic, it actually, instead of losing potassium, you don't lose it. It's like a basket at the end of your kidney, and it just saves that potassium. And I use it all the time, and it's actually a great drug.
I use it with heart failure because aldosterone or aldosterone is one of those same hormones that go too high and worsens the heart failure.
And there's been multiple studies that aldosterone is actually a bad hormone as well. So blocking it is
a good thing to do.
Is a good thing to do.
I'm sure there's times when you need. I mean, Mother Nature does things pretty well.
Yeah.
But I'm not quite sure where we're at with that. So spironolactone, a good drug to use. Not always.
Always.
Got to be careful with the potassium.
And especially with kidney disease as well. People who don't regulate potassium properly sometimes get in trouble when you are on spironolactone.
So I monitor potassium, and that's something your doctor should do if you're on these diuretics.
Definitely. I agree.
Dialysis is a life-saving procedure for those whose kidneys have ceased to function. Some patients have problems with the process, and the experience is negative, to say the least. However, there are those who have come to grips with the lifestyle changes it requires and view it as just something they have to do.
I developed diabetes probably back in the early 90s is when we finally diagnosed it. And then the doctor told me, your kidneys are quitting, a little more, and all of a sudden they went haywire. Next thing I know, I had a hose in my throat, and they were dialyzing me. And then they put the fistula in, and that's where we hook up now. Go up 3 times a week, 3 hours and 15 minutes each time. I mean, there's good days and bad days. I mean, if I get a day like if I take off a little bit too much fluid, the blood pressure tanks out, and that day is pretty well shot then until about 4 o'clock in the afternoon, because I'll come home and I'll sleep all day. Or if you draw a little bit too much off, you'll get leg cramps and stuff, and that kind of wears you out too. But as a rule, if I watch what I take in, don't overdo it, we don't have too much trouble. If I want to go someplace, I call her up, say I want to go here, such and such a date, so they'll call ahead and find places where I can. In fact, there's even a cruise line out, goes up the Alaskan coast that has dialysis right on the ship if you want to go. Don't wait too long. I mean, it's really scary when you start out with it, They talk of dialysis and you have this, oh God, I'm going to die real quick and all that. All the old terror tales from the beginning of it. And you feel so much better after you get going on it. I mean, it might be a little tough getting started on it and stuff. We got a surgery or two to get the fistula going and getting that started. Sometimes it's a little. I had kind of a rough time getting it going. I was black and blue from here clear down to my wrist when we got started, but that happens. But once it gets going, now it's just. Well, they've got lidocaine, that helps. We might mention that the diet is all. You change that all. And you work on the precedents. If you like it, you're probably not supposed to have it. They really watch the potassium and phosphorus intakes. And then the pills they give you to help get rid of the phosphorus, that builds up the calcium, and then you got to watch that. So you've got a balancing system there where you try to go through. And then they draw blood once a month, and then you adjust meds or adjust your eating, whatever it takes. You got to look at it like a job, and it goes a lot better. Some people, they moan and complain about it, but yeah, given the alternative.
That was an interesting story about dialysis, and it pointed out the vigilance that it requires of the patient when they're on dialysis. This is a person on hemodialysis. Talk to us about what that is.
So basically, hemodialysis is a machine that takes blood away from you and puts it into a filter and basically cleans the blood and brings it back to you, preferably through a fistula. What they call a fistula is actually a shunt, a natural shunt that's made from your own vessels.
So they connect a vein and an artery.
They connect a vein and an artery. Then the artery actually feeds the vein, and the vein becomes thick like an artery. The nice thing about that, it produces enough blood flow for the machine to clean your blood.
But you know what it does is it shunts the artery, the blood that's normally going out to your hand,
Yep.
and so you have less blood flow to your hand. You ever run into problems?
I actually run into multiple problems. Usually there's always two vessels that feed, for example, the arm.
Right.
But sometimes, unfortunately, these patients have vessels that aren't perfect.
Right.
And sometimes that other vessel that supposedly should feed the arm get in trouble.
Yeah.
And sometimes they could have what they call they had problems with blood flow down there, and we have to cut it down.
Yeah, you remove it and you let it return the blood flow.
Exactly. It's called steal syndrome.
It steals the energy
blood
from the blood from
exactly.
the hand. What about other access areas when you're waiting for a shunt that you've asked the surgeon to make? You know, they go in and they make that connection, and then it matures.
Sure.
While you're waiting and they need dialysis, how do you access this in and out, this big vessel in and out? You have to take a lot of blood out fast, put a lot back fast.
So basically, the ideal blood flow is 400 cc's per minute.
That's a lot.
That's a lot of blood. That's how fast we want to take blood away from a person.
Right.
Unfortunately, sometimes a fistula is not ready when you're on dialysis, and that's why we want early referrals to a kidney doctor, so we can get the fistula in
before they need
dialysis. And it's not something that will hurt you most of the time. It's just sitting there as a safety net.
Yeah.
So unfortunately, if you're not ready, if the fistula is not ready, you're going to need to have what they call a catheter in your chest, in your blood vessel, because we need blood flows that are so fast. We need the biggest veins in your body, and usually that vein is inside your.
Do you do a subclavian? Is that where you
usually we don't do subclavians, but the problem with subclavians is if you put a foreign object there and they stenose, your whole arm gets into problems. So what we do is we put it in the IJ, in the intrajugular vein. So it's usually in the neck.
Okay.
But what we do is we tunnel it under the chest so it goes into the subvessels. And as you can see, if you think about it, there's an open wound there every time. And usually those catheters are a few inches away from your heart. And the risk for infection, as you know, would be very high.
So it's nice to get rid of those when you can and have this fistula working nicely.
Pretty much.
Yeah, there. So that's hemodialysis,
Sure.
but there are other kinds of dialysis.
Exactly. And the funny thing is, I went to a meeting where there is probably 1,000 kidney doctors there.
Right.
And out of the 1,000 kidney doctors, 900 want to do home dialysis. And they ask the doctors again, what kind of dialysis would you give to your patients most of the time? And they say the hemodialysis, which is the one in the hospital.
Right.
So home dialysis, it's two different modalities. Okay, one is similar to what they do in the hospital.
But the machine is at home.
But the machine is at home.
You have the family.
You have the family.
Or a visiting nurse or something like that.
Exactly. The problem with that is people don't like the sight of blood.
Yeah.
Yeah, it's a little nauseous to them.
Some people can't handle it.
They can't handle it. And some people can't put a needle in their vein.
Right.
Yeah. So what they do is what they call peritoneal dialysis. Peritoneal dialysis is putting a catheter in your belly. This is where your gut is, and this is your abdominal wall. There's a space there where you put the catheter in, and you actually put fluid there, sugar water.
Right.
And you keep it there for a couple of hours. And since there's a lot of blood flow in the gut, it transfers the waste products from there to that clean fluid.
Right.
And that fluid actually becomes urine.
Right.
Then you basically
Drain that
out, then bring
more sugar
water back in, then drain it back out. It's like a washing machine, basically.
Yeah.
And to be honest with you, if I had to be on dialysis, knock on wood,
that would be
my choice.
You know, I made the diagnosis of acute renal failure. It was acute glomerulonephritis on a gentleman maybe 15 years ago, and I sent him to somebody like you, and they started him on home peritoneal dialysis. I mean, a very independent man, wanted to continue to teach, which he did at the college, and he did that for about 2 years until his transplant.
Exactly.
And it worked great for him. I had another elderly patient, the father of one of my closest friends, who lived with peritoneal dialysis for many years. He'd just go to bed at night. They had a machine that would put in the sugar water, take out the old sugar water, put in new sugar water, and do it all night long, and then he'd get up the next day and have a normal day. It had all happened during his sleep. He wouldn't have to go somewhere and be connected to this.
And I'd like to talk more about the dialysis in the hospital.
Okay.
So basically, if you think about it, your kidneys work 24/7, 24 hours, 7 days a week. So when you go into a hospital, they do it 3 times a week.
Right.
So usually it depends on how big you are. Usually it ranges between 3 hours to 4 hours each time. So that's if you're doing it 4 hours, that's 3 times a week. That's 12 hours of your day wasted.
Yeah.
Sitting in a chair hooked up to a machine.
Right.
Not able to do anything. So unfortunately, sometimes that's the only choice people have. But people who are healthier, that's why I push them to do the home peritoneal dialysis.
Yeah.
So, and the amount of money that the government spends for dialysis is astronomical. Usually they pay $130 for each treatment, for each person. The funny thing is there's more than 500,000 patients on dialysis, and almost a quarter of the whole Medicare budget
is on dialysis. Now it's interesting, but you don't have to be a Medicare-aged person. Sometime back in the, and I think it was like late 70s, they just passed a law and said Medicare will cover
pretty much
all the people on dialysis.
So basically, as long as you're Medicare eligible or social, you've been paying Social Security.
Yep, you can get it.
You can get it for free.
So
in this country.
In this country. Now the question I would have, and you tapped on this, what is the cost difference between home peritoneal dialysis, which is, as you say, something that works just as well, and you do it every night, then you do it while you're sleeping, versus this 3 times a week stuff? What's the difference in the cost?
It's quite a bit. I don't have the numbers with me, but actually the
half price,
pretty much, nearly, almost. It's because you need to have nurses, you need to have a building, those things.
Yeah.
So that's the reason why it's so expensive.
Well, and of course some people can't do that. Can't do the peritoneal.
And unfortunately, they can't do it sometimes, and they don't have a good family support or something similar to that. And I understand that, and that's the reason why. Those are the only people that I bring to in-center dialysis.
Yeah. Now, another thing I read, as you read a little bit in preparation for these shows.
Sure, definitely.
There is a recent article that said the more dialysis you have, the better you do.
And that's actually one of the new things that are coming out. More of the studies, and this is similar to what I've been talking about earlier. Your kidneys work 24/7.
Yeah.
It does not work 3 times a week.
Right.
Yeah.
And it would be nice to be able to do it, and you can do it at home every day or every night. And,
so what people do is basically sometimes they go to a hospital and hook themselves up to a machine while they sleep.
Yeah.
And they basically dialyze that way. And studies have shown people actually do better from them. So, which just makes sense to me, I think.
Yeah.
So
so there's our plug for the day, really. Yeah. Home dialysis, maybe home dialysis.
Maybe home hemo.
But also it could be, which is the machine IV. Yeah. But it could be peritoneal dialysis.
Exactly.
And the advantages are really that you can be at home
and people think that I can't do this. And I actually brought that up to one of my colleagues in the meeting. I said, look, I've been trying to push this all the time, but I've got a lot of pushback from my patients.
Yeah.
And people tell me, look, I told them most of my patients are farmers. They're not used to these machines and those things. And they told me, you know, the farmers are probably one of the most smartest people around. They have big combines and everything, and they can definitely take care of those.
They can do
anything.
Yeah, they can do anything. I mean, you know, that if you're going to be successful in farming,
exactly,
you can do it, and you are one smart man or woman. That's right.
So,
well, let's talk about the diseases that cause this. You know, we all know that there are inherited diseases, polycystic kidney. Tell us a little bit about that.
So basically, unfortunately, if you have one family member, if you got, if you've got polycystic kidney disease, one of your parents have polycystic kidney disease, it's a 50-50 thing that you can have polycystic kidney disease.
Yeah.
Unfortunately, you'll find out when you're a young adult if you have polycystic kidney disease.
And do all of these go to renal failure or kidney failure?
Eventually.
It's just a matter of time.
It's just a matter of time. And unfortunately, you can't do anything about that.
That's a thing to do.
Not a thing to do. The only thing that you can do is basically avoid the ancillary things that can cause kidney disease.
Anything that's toxic to the kidney,
exactly.
You're going to avoid.
Hypertension, those things.
Right. So let's take that's an inherited, and there's other inherited causes,
sure.
but that's the big one.
That's one of the biggest ones. That's true. There's a little less common things, but nothing really worth talking about.
All right. Now let's talk about the acquired diseases that happen as a result of, let's say, hantavirus infection, sure. or a strep infection that might trigger glomerulonephritis, or lupus, or rheumatoid arthritis. These immunological diseases.
Sure.
What about those?
So basically, the nice thing about those things is you can do something about them.
Say that again.
You can do something about those things. For example, if you've got lupus, you can treat the lupus causing the kidney disease.
Right.
But unfortunately, for example, if you have hantavirus, if you have strep, what can you do?
And it just triggers your immune system. And your immune system attacks your kidney.
Basically, they think that your kidneys are not part of you, so they attack it.
Yep, and destroy it.
Then they destroy it.
It's just a fluky deal.
Exactly.
So you try to treat that as well as you can. Then there's the other kinds of things that you can do something about.
Sure.
And we can talk about obesity. And diabetes. Does obesity alone, without diabetes, cause kidney disease?
Obesity actually can cause kidney disease as well. Interesting that you said that. I actually just diagnosed someone who was quite obese and in his 30s to have kidney disease.
And nothing else?
Nothing else.
Doesn't have diabetes?
Doesn't have diabetes, doesn't have anything.
It's the same story about the liver. If you have obesity, you get fatty liver disease, exactly. and cirrhosis and cancer of the liver as a result.
And it's scary because I actually read an article that in 2034, I think 50% of Americans will be obese.
Oh yeah, I mean the number just came out. It's just terrible.
It's terrible.
We need to do something in our country about this epidemic.
Definitely, I agree.
I think it's a tough issue because the people who are heavy don't want to be heavy.
No.
We're going to come back and talk about obesity and diabetes, but we have something else to talk right now. Transplantation. Transplantation of a donor kidney, either from a living donor or someone who has died in a way that didn't harm their kidneys, is often a life-saving event that permits the recipient to live without the need to use dialysis.
Well, I'm diabetic. At this point, I've been diabetic 50 years. And 23 years ago, I got a transplant at Hennepin County Medical Center in Minneapolis. They were one of the first places to do kidney transplants. And I was on dialysis for 2 years before that. My kidneys started to fail from the diabetes, from hardening of the arteries. And at that point, they told me that I needed to go on dialysis. I was on a waiting list, and they called me and one Saturday morning about 10 o'clock and said, "How soon can you get here to Minneapolis?" And I said, well, it's a 4-hour drive, and I got to pack my bag. By 4 o'clock, I can be there. So I rushed around and made arrangements and got there, and they took me, well, they dialyzed me one more time, and then they took me to surgery. And they had gotten a kidney for me from a young girl in Tennessee, a 16-year-old girl who had died, and they harvested her kidneys. They have antigen matches, 5, 6, 3, 4. The better antigen match you are, the more successful the transplant is. And mine was 5 antigens. And so I've never had any rejections with my kidney from this girl. I love having the transplant. I didn't feel very good on dialysis. It felt like I had the flu because some of my body chemistry was off, such as the potassium and the calcium and the phosphorus. Because you have artificial kidney through the dialysis, it doesn't get all the chemicals out the way it should. I was better right away. It was like I was right back to normal, like I hadn't even been sick. I'd say if you're in good health and feel like you want to give to someone, put down that you'll be a donor. I'm really, really grateful to the family that did that. They gave it up.
Transplantation, amazing. Before we talk about it, I wanted to tell you we're going to go back to obesity and causes of hypertension or blood pressure or kidney problems. But talk to us about transplantation. I mean, you can do a cadaver.
Yep.
A donor, which is from a dead person who died in a car accident.
Yep. And there's 2 types of cadaver donors, which is one is basically someone who's an unfortunate young adult, 18-year-old, passed away through a motorcycle accident. And that's what I call a brand new kidney.
Yeah.
And there's what you call an extended donor kidney, who's someone like you and me. A little older.
Okay.
Yeah, but healthy.
Yes.
Okay. But it's going to work nice enough.
So let's say there's an 18-year-old person, they get an older guy's kidney.
Sure.
How long does that kidney last?
Usually around 12 years, 12, 15 years. So that's usually the time.
From an older person?
Yeah. Oh, from an older person?
For any person?
So usually if you get an older kidney, it lasts lesser than a newer kidney, from a younger adult kidney.
But the average is 12 or 15
probably between
years?
8, it depends, 8 to 12 years usually.
Really? Not longer than that? I've got a 40-year patient, and Julie just spoke to us.
Exactly. And if you think about it, there's a big range. Some people have the kidney for 3 months. Some people I actually have a patient who has a kidney for 40 years.
Yeah.
And there's always, the living donors are always the preferred kidney.
From the cadaver.
Exactly, especially relatives.
Because they're matched
much more nicely.
Okay.
If you think about it, your mom is half of you is from your mom, half of you is from your father.
Yeah.
If you got a kidney from your mom, half of the kidney is from you.
Yeah.
So matched basically.
It's matched by me 50%.
Yeah. So that's the thing.
So many donations are from living donors.
Yeah. Actually, most of the donations are actually from deceased donors. That's the thing. And that's the reason why they needed to do that other kidney from older people, because there's not enough pool. And for some reason, living donors are not
coming forward. People are afraid.
People are afraid, definitely.
Well, what can you do to allay the fear here? I mean, is it, and can you do it honestly?
Sure.
How safe is it for me to donate a kidney?
So basically, 2 things. The kidney doctor of the patient who has kidney disease is different from the kidney doctor who will look at you. It's going to be very confidential. So basically, you need to pass through the eye of the needle, is what I tell my patients, before you can give a kidney.
Okay.
So the risk of being on dialysis after giving a kidney is very, very low.
I mean, it's virtually the same as if you hadn't donated.
Exactly. People actually who donated are healthier than people who didn't donate. The reason behind that is because people keep on being followed up after donating a kidney.
Well, and also there's something about the attitude of a person who's willing to donate.
Exactly, that's true.
I think about Jim Abbott, who is the president of the USD, who donated his kidney for one of his teachers.
Oh, I didn't know that.
Did you not know that?
I did not know that.
So now there's a gift. I mean, that's a loving gift. And I suppose, you can argue, well, he really needed that teacher. Yeah. But it's a beautiful, beautiful thing. I mean,
exactly.
Well, let's.
He was probably a good teacher.
I can tell you, and he's a pretty good president too.
Yeah.
Let's talk about the problems that cause kidney disease. Besides what we talked about was the congenital things, and we talked about the acquired immune system problems. And we started with obesity. Let's talk about diabetes. Is that the most common cause of kidney failure?
That's the funny thing. Basically, the things that we talked about earlier, those are actually rare and far in between. Most of the causes of kidney disease and kidney failure in the United States is actually because of just two things. It's because of diabetes and high blood pressure. So diabetes is actually the leading cause of kidney failure in the United States.
Right. Now, if I'm diabetic, that just is chilling to me to hear that.
Exactly.
Okay. So what can I do to make sure that I'm going to prevent my kidneys from getting damaged from my diabetes?
So basically, it takes 5 years of diabetes usually before the kidneys get affected. And the reason, and the main thing that you need to do is control your blood sugars. There's a thing that you call the hemoglobin A1C,
yes,
which you check every 3 months, which is an indicator of how good your blood sugars are.
Right.
And that should be below 7. My recommendation is actually even go lower to below 6.5. And working with your doctor, primary care physician, is key to that.
Okay, so I'm going to argue with you.
Yeah.
Okay, I know that the original study said 8.2.
That's true.
Remember that original study in the New England Journal? And so they said 7 because they wanted to have a buffer that's safer.
Sure.
And we also know that there is data to say of late that if you're trying so hard to control that diabetes, see, I try to control diabetes, you've got the kidney.
Sure.
I got the patients with the diabetes.
Sure.
You try so hard, you can get people going too low and they pass out and break their hips. You get too low and they have low sugars and they burn brain cells. They have all the complications. And some say that it's really a J curve or a U curve, and that level of where the damage is occurring is in the 8s, like the original study.
Yeah.
Would you agree?
I probably lean in the 7 range. I like it in the 7 range at least, is my preference.
You really want the kidneys protected.
Yeah, basically. I'm a kidney doctor, so
Yeah.
I protect my kidneys
There
just
you
like
go.
a heart doctor who protects the heart.
Okay, so but we can argue a little, and that's all right. We don't. Everybody doesn't agree 100%.
Definitely.
But we want the control, and I think the biggest problem and the most important thing about diabetes is if you can control that sugar with a non-medicinal method, which is weight loss and an exercise program. Yeah. And that has to be pushed harder in this country.
And the funny thing is, people think that the medication is the thing to treat them. They don't understand that if they lose 20 pounds, they don't need to take medications.
Yeah.
That's the thing.
That's the thing.
And
I think that's the story about heart disease as well.
Sure.
We think, I had a friend say to me, I don't want to exercise, I'll just take the lipid-lowering drugs.
yeah.
Not a comparison to which
Exactly.
is effective. It's the
Exactly.
exercise that matters. So let's talk about hypertension as
Sure.
a cause of kidney disease. What's the data on that? What do you know about that?
So the funny thing is, with hypertension, kidney disease is one of the most common causes of secondary hypertension.
Right. Is it high blood pressure that's causing the kidney disease, or is it kidney disease that's causing the hypertension? The
It's like
chicken,
the chicken and the egg. Exactly. So the recommendations based on old studies is below 130 over 80. The top number is 130, below 130. The bottom number is below 80. But studies have shown that actually you can actually go a little higher than that. So, and my preference would be the latter.
Yeah.
So as long as it's in the 130s, I'd be okay with that.
Right. I heard at the National ACP meeting, the internist meeting in New Orleans this year, that 140 was the number he wanted. That was the
Exactly.
cutoff for me, he said, 140. If you're under 140, okay, I'm not going to add more pills.
Exactly.
And certainly, though, I always start with the most important thing to lower blood pressure, which is exercise.
Exactly.
So, so lowering the blood pressure with exercise primarily does more than
That's
just
true.
a pill and lowering pressures. It does all these other good things.
And the funny thing is, there's also been studies that if you lose 10 pounds, you lose 5 points in your blood pressure.
Yeah.
So, I don't want to come back to our initial conversation, but with salt, people who actually took 1,000 milligrams of salt, who have high blood pressure,
Yes.
actually brought down their blood pressures sometimes 5 to 10 points.
Right.
So that's the thing.
So if you're a person who's salt sensitive,
Yeah.
it really makes a difference.
Definitely.
But then there's some people who you can mess with salt and it doesn't change
No.
anything as well.
Yeah.
And you need to do the blood pressures, control the blood pressures. It isn't just the kidneys. It's your brain. Even if there aren't big strokes, there's these little strokes and people get duller and they lose their mental capacity.
Exactly. And unfortunately, it's like having a workout every time. Your vessels are having a workout every time if you've got high blood pressure. And if that's the case, your vessels will become stiff, and even any kind of medication won't work if your blood vessels are already too stiff.
You made a comment, though,
Sure.
that chicken-egg story, that
Yeah.
sometimes you get kidney disease and then you have subsequent high blood pressure. Talk about that.
So basically, the thing with kidney disease is when you have kidney disease, you can't get rid of the excess salt.
Right.
So when your kidney disease gets worse, eventually it's much, much more difficult to control blood pressures.
Okay.
Not just because of that, there's also medications that you can't use anymore
Right.
when you've got advanced kidney disease.
Right. Okay, so let's talk about medications.
Sure.
There are people who say that one of the major causes of kidney disease in this country is analgesic abuse. And I know that there's this kind of this shrunken, dented, funny-looking kidney that can happen as a result of, somebody said, years of Tylenol, ibuprofen, naproxen, all of those pain medicines.
Yep.
What's your comment?
Actually, I never take Aleve, Motrin, ibuprofen. And outside of the United States, those are actually drugs that you need a prescription for, because they actually are one of the most common causes of high blood pressure and actually hurts your kidneys quite a bit.
If not saying anything about your esophagus and your stomach.
Exactly. That's the first thing I tell my patients. Have you been ask my patients, have you been taking Aleve, Motrin, ibuprofen, naproxen, those things? And they seem innocent, and unfortunately they're one of the best pain medications
Yes.
out there, if not the best. But they just harm the kidneys in so many ways.
I'm with you. I use Tylenol,
Yeah.
and I only use it as needed.
As needed.
And I don't do I'm going to hurt tonight, so I'm going to take a little tonight so I can sleep better.
Sure.
I just don't use it unless I'm in a significant amount of pain.
And I agree. That would probably be the way to go.
There was one study that said that if you have 10 years of the equivalent of more than 2 Tylenol a day, that's 325, not
Sure.
the 500. 500s a day is over the limit. 800 was the limit.
Yeah.
800 milligrams. If you have more than 800 milligrams a day for a lifetime, for 10 years, you're going to have kidney disease from it,
Yep.
from Tylenol, and probably about the same thing with naproxen and with ibuprofen.
Probably much worse. Much worse. Would be my guess.
So there is a real story about use of analgesics in
Definitely.
kidneys.
Definitely.
But
Especially elderly folks. They're more prone to these diseases, especially because they're on other medications that, when on top of being on these analgesics, actually hurt the kidneys even more. So, for example, if you're on a fluid pill or other blood pressure pills, on top of that, you're on that
Analgesic.
That's
Double trouble.
It's double trouble.
And as you were saying, let's say you had some kidney disease from other things like early polycystic kidneys or something else. You start adding these things, and then they push them over the edge.
Exactly. So you basically just want to make sure that you're not taking anything that will hurt your kidneys. or else you'll get in trouble.
So have we missed anything about causes of kidney disease that we should...
I think those are the most common ones. It's diabetes, high blood pressure, and glomerulonephritis, which is basically the inflammation of the kidneys we talked about earlier. They comprise roughly 70 to 80% of kidney disease in the United States, or in the world even.
So that's about 80% of it.
Exactly.
Well,
so,
very good.
Yeah.
I was just turning 30 years old when I first noticed blood in my urine. I tried the time-honored method of ignoring it for a bit, hoping it would go away, but it continued. So I saw a doctor friend who thought it might be from a kind of kidney disease innocently called minimal change disease. He said, this means that it could be up to 10 years before your kidneys would fail. I think he was trying to be reassuring, but it turned my blood cold. Making the story short, the blood was not from the kidney, came as a result of jogging, and thankfully, here I am 33 years later with working kidneys. It made me reflect not only on the direction of my life, but also on the causes of renal failure and kidney disease. There are many inherited reasons for the kidney to fail, the most common of which is called polycystic kidney disease, where the kidneys become filled in by cysts which choke off normal kidney function. There's little any individual can do to prevent something like this, since it happens by the luck of a genetic coin toss. Kidney disease can also be the result of many acquired conditions. Several are caused by the immune system gone awry, which follows infectious conditions such as hantavirus and certain streptococcus bacterial infections. These are simply the consequence of a bad break, being at the wrong place at the wrong time. What is most important to realize, however, is that there are many causes of kidney disease that can be prevented. Of course, high blood pressure, obesity, and diabetes all run in families, but unlike polycystic type of condition, these can often be effectively treated with appropriate medicines and with a lifestyle change of exercising more and eating less. Sometimes kidney damage results from certain medicines, such as a common Chinese herbal medicine or kidney toxicity from too many pain relievers for too long. You should know that daily doses of Tylenol, Advil, and Aleve for many months could actually harm your kidneys. It's 33 years after a big scare in my life, and I do not take my health, and especially my kidneys, for granted. Neither should you. Well, Arvin, what's your take on that essay?
I think the take-home message is most of the kidney failures are due to something that you can control. And if you take care of yourself, exercise, diet, lose weight, you probably won't be on dialysis. Even if you have diabetes, even if you have high blood pressure. You have control of your life, basically. So people who are not taking care of themselves are the ones who usually end up on dialysis. But some of them you can't really control. So
that's an important lesson about lifestyle. I mean, we pound it and we pound it and we pound it, and I say, you've got to exercise, and I see them next time and they say, well, I didn't do very good on that.
Sure.
Do you have a way of getting people to exercise better than I do?
Not really.
It's a tough one.
It's a tough one.
We don't really, by nature, I think humans take the easy road. I mean, it's always a better way to do that short distance than walk around the block to get to the same spot.
And I think even the food that we have right now, the fast food culture, those are the things that are pushing us towards the obesity problem that we have right now.
Yeah,
so.
that's a bigger part.
Exactly.
30 seconds.
Sure.
Take home message for our audience.
So basically, my take is take care of yourself, diet, exercise. Even if you have diabetes, even if you have high blood pressure, these things can be avoided. The kidney disease can be avoided even if you have those things.
Yeah, well, I can tell you, it's been a joy to have you here. You speak like a guy who grew up in DeSmet, South Dakota. I mean, your accent is so perfect.
Sure.
And what a joy to have a good nephrologist as not only a consultant but a friend. Thank you for being here.
Thank you very much, Rick.
That's great.
Thanks for having me.
That closes our show on kidneys and renal disease. I sincerely thank our studio guest, Dr. Arvin Santos, a nephrologist who practices at the Avera North Central Kidney Institute in Sioux Falls, for visiting with us about this very important topic. Lord Byron thought he had the best prescription for life. Always laugh when you can. It's cheap medicine. Until next time, stay healthy out there, people.
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubak with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.